Radiation oncology is a field of medicine where we use high energy radiation beams to kill the tumor cells. There are many types of radiation beams, such as the electromagnetic radiation or photon beams, electron beams, heavy ions such as protons, neutrons, and also the other one that we are talking today is about brachytherapy. So what is brachytherapy? Brachytherapy uses the same radiation that we use in the external beam radiation, such as the electromagnetic waves and the electrons. However, here in brachytherapy, we treat it in a very precise manner by placing the tubes into the tumor. So the brachytherapy can be a high dose rate brachytherapy, low dose rate, or intermediate dose rate, where we place the radioactive seeds into the tumor. The word brachy in Latin means short. So brachytherapy means short range therapy. That means in a very short range, unlike the external radiation where we shoot from a distance like 100 centimeters away. Here is we precisely place the needles into the tumor and we sterilize it. So currently most centers around the world uses high dose rate brachytherapy using the source iridium-192, which is a synthetic radioactive source. The aim is to deliver ultimate lethal dose to the tumor cell. What is ultimate lethal dose? That means we give a dose of radiation that nothing actually survives, and this is how we sterilize the tumor. So because in brachytherapy we can be very precise and we can place the needles into the tumor, very high doses of radiation can be given to the small area while limiting toxicity to the surrounding structures. And also another advantage is, when we have breathing motion, like we are treating a tumor in the liver is moving up and down. When we use brachytherapy, there's less issues with that because we place a needle or plastic tube into the tumor. When a patient is breathing, the liver is moving, the tube also will move with the breathing. Unlike when we use external radiation, we may miss the target. However, it has a steep learning curve. For the specialists and doctors who perform brachytherapy, it has a long steep learning curve, and it comes with experience that we can improve further. Today I would like to touch on the type of brachytherapy treatment that is done at Pusat Perubatan USM Pertam. While these are not comprehensive, there are more brachytherapy procedures that can be performed. These are the one commonly that we perform in Pertam. So one of it is high dose rate liver brachytherapy. High dose rate brachytherapy, as I mentioned earlier, is a form of minimally invasive radioablative treatment directly targeting the tumor here in the liver. So we call it a liver directed therapy to sterilize or clear the tumors in the liver. Other options when we have a tumor in the liver include surgical removal, which is the most common option and standard option, radiofrequency ablation, which uses the heat, microwave ablation, ethanol injection, and selective intraarterial radiotherapy, and at times also transarterial chemoembolization. This brachytherapy to the liver can be used for both the hepatocellular carcinoma and metastatic tumors to the liver. What are the advantages of this liver-directed brachytherapy? One is, if you look at the heat-based, something like the radio frequency or microwave ablation, whenever the tumor is beside a big blood vessel, when we use heat, there's something called heat sink effect, whereby all the heat are dispersed by the blood that is flowing, and then it becomes less effective. Also, in radiofrequency ablation, there is a limit on the size of the tumor and number of lesions, because if the tumor is too big, more than 3 to 4 centimeters, it's not very effective. And In some tumors like hepatocellular carcinomas, we realize that they are very radiosensitive. What radiosensitive means is even at a lower dose of radiation, the tumors tend to disappear. And also we can target very difficult anatomical locations, like subdiaphragmatic tumors, which is very difficult for radiofrequency ablation and heat-based treatment. We are one of the 4 or 5 centers around the world who are actively doing this liver brachytherapy. The rest of the 3 centers are in Germany, and we are one. And there's one center in India that used to do liver brachytherapy, but our numbers probably are second highest in the world. The next one will be high dose rate tongue brachytherapy. So my colleague Dr. Jasmine would have spoken about the tongue brachytherapy. Just to touch a little bit, we came up with a novel method which is called hybrid brachytherapy followed by intensity modulated radiation therapy. With this, we are giving patients an option, non-surgical option, to actually treat tongue cancers. It is an organ preservation option whereby the tongue is preserved, and from the data that we have, the quality of life has been quite good. Head and neck brachytherapy is when we treat the same method like in tongue, but we treat the head and neck region. So in the same concept how we treat the tongue cancers, here we treat the lid, the buccal mucosa, and the rest of the areas, sometimes including the skin. Also, usually it's reserved for patients who are unfit for surgery. The next one will be esophageal brachytherapy. Esophageal brachytherapy, we can offer it as symptomatic in a palliative setting, whereby patients who cannot swallow, we put in a tube and then we radiate the tumor intraluminal. Or we can even do the brachytherapy in the form of radical treatment aiming for the cure. The advantage of esophageal brachytherapy compared to putting a stent in is that patients have better quality of life, less retrosternal pain, less gastroesophageal reflux disease. And because we give a high dose of radiation to a small area, the chances of ensuring that we sterilize the tumor in the esophagus is much higher. Palliative brachytherapy is another form of radiotherapy to patients who have incurable disease, and we want to palliate the symptom. That means we want to make them feel better. This palliative brachytherapy is hardly performed around the world, more because of the lack of expertise, and also many of the radiation oncologists are not aware that this type of therapy can be performed. The advantage of palliative brachytherapy is more usually in a setting whereby patient already had radiation before and the tumor did not respond well, or it grew after the radiation. So when we do a palliative brachytherapy, we can give much higher doses compared to external radiation to ensure that the tumor is well controlled. Brachytherapy for endometrial recurrences. So these endometrial recurrences is in women who had uterine cancers or cervical cancers, who already had the surgery to the uterus, and sometimes at the vaginal wall or the remnant of the vagina, the tumor may actually come back. So this scenario, when the tumor comes back at the vagina, this is an area of need where there is not much of options left. What is frequently done now is we do external radiation, and at times we continue with chemotherapy and all. But here need to be remembered that by doing a very focused radiotherapy to the wall recurrences, by putting the tubes in and giving high dose, especially in the setting of patients already had radiotherapy before, we can actually sterilize the tumor at the wall, and it can be curative for a patient. We have a series of around 8 patients that we have treated this vaginal wall brachytherapy, and all of them had complete response of the tumor. The surgery in this scenario can be even a pelvic exenteration and removal of bladder, and all the functions can be disturbed. And wall brachytherapy is an option actually to preserve the structures, and with much lesser toxicity, hopefully, from what we have seen in our series. We are the only one actually offering it in the country right now, and even in places like Singapore regional, nobody is offering this. Breast brachytherapy is a form of brachytherapy now being performed in many sites around the world. They are actively venturing into it. While there are some advantages, here in PPUSMB we are focusing more on breast brachytherapy for patients who refuse surgery, unlike in other parts of the world where they do it for patients who had surgery and to give a focused radiation to the tumor bed. In this scenario, a patient who refuses surgery, while surgery is the first option, we can actually put the needles in and give high dose of radiation to the breast tumors. Prostate brachytherapy is another form of brachytherapy which has been traditionally used in many parts of the world. While the interest is going down because of the newer technology, but there is still some advantage of prostate brachytherapy, especially in the setting when patient already had a radiotherapy before, and then they may have isolated recurrence in the prostate, a small tumors or what. Then we can use a transrectal ultrasound guidance, and then with that we use a prostate template where we can look at the tumors well, and then we insert the needle directly into the prostate. We also perform a gold seed markers here, whereby we put gold seeds into the prostate as to help us with the targeting of radiotherapy. Radiotherapy method instead of surgery for prostate cancer control currently is showing equivalent to the surgery, but with a different toxicity profile, and many patients are opting for this. So talking about this brachytherapy, because in PPUSMB we have spearheaded brachytherapy and we became the leader. I would say it's a world leader in brachytherapy. We perform the most number of brachytherapy, most number in terms of different sites of brachy. If you look at Germany, mostly they do liver brachytherapy and they are focused on liver. There are some centers in Japan which focus on tongue brachytherapy. Australians, they do prostate brachytherapy. Gynae brachytherapy is more in Thailand. The cervical brachytherapy. But here in PPUSMB and USM, the good thing is that we do a wide range of brachytherapy from head to toe. We have treated most sites from liver to lung, prostates, rectum, gynecological brachytherapy, head and neck brachytherapy, tongue brachytherapy, esophageal, and many sites. But despite that, there is still a huge potential and area of research in this field. One important thing that made us possible that we can treat this wide range of tumors is the physics support. The medical physics at University Science Malaysia has been very good and very supportive, and the team consists headed by Dr. Zahri. We had a computerized treatment planning system, and with the treatment planning system we managed to treat in many sites of the body with the computer algorithm, unlike when we used to do a manual calculation 10 to 20 years ago. However, the computer planning and algorithm can further be improved, and this is where we need more of this School of Mathematics or Computer Science to come in to look at how we can improve further on the algorithm. It is also a minimally invasive procedure. Minimally invasive in sense we are putting a small tubes. Currently we are using a 6 French plastic tubes. Probably we can go to even a 4 French. We need to look at the material if we can use a very small tube so that we can reduce any risk of injury to the structures. And other parts that we are looking at is whether we can combine this brachytherapy with the immunotherapy or targeted therapy to improve the patient outcomes. And then we want to look at some toxicities of this brachytherapy, like in the tongue area, patients may have injury to the gum or the mandible because the tumor is too big, and how to deal with this osteoradionecrosis or the side effects of treatment. We also want to look at, rather than treating the side effects, patients just say like tongue cancer, if they can come earlier. If they come earlier, we can treat them much earlier and less side effects. So we need the public health to go out and dental public health and everyone to go out and educate the patients, come early for treatment. We have an option. We can even give you an option of tongue preservation and everything. The tubes and all these equipments that we use, the disposable, sometimes can be quite expensive. So this is an area of research where can we produce it in-house here and look at it, how we want to reduce the cost to the patients. These are the type of things that we can think about. And more uses of brachytherapy, yes, something that we can actually discuss in detail, whether it can be applied to even a non-cancerous tumors or different sites. What's the benefit in tumors that is not where brachytherapy has not have a role so far. So it is an interesting field of brachytherapy. And myself as a brachytherapist, we are very happy to share this knowledge, and we can see how we can work further on this. Thank you.